Okay.
All right. Well, welcome, Mackay Asbury. We're delighted to have you share with our friendship group today and tell us about caregiving options and what we should be thinking about for ourselves and our family members.
Yeah. Thanks, Susan. I was trying to think of how to begin all this, and I guess one of the ways I wanted to start was for those of us who've been Glen members a long time, and considering I was born into the church back when Chandler Budd was the pastor. I just really recognized how intergenerational Glen Memorial is. I mean, even as a kid, a teenager, a young adult, and whatever, it's always been a great mix of young people, but all the way through to seniors. And I think that's provided a lot of comfort for a lot of families to just feel comfortable with all the various age groups. And since we're talking about healthcare at home, it's probably more relevant to those that are, our older parishioners at Glen. And I'm becoming one of those now. But certainly, with my mom at 93 and all of our good friends that where she lives over at Claremont Place, or my grandmother, Ms. Mackay, lived to be 100, so there's longevity in my family, and so it's there's always been a lot of interaction with older uncles and people at Glen Church. So it got me thinking one day several months ago about healthcare outside the walls of the hospital, or the AG Roads, or the Bud Terrace, or the doctor's office. And I've had the privilege to work in, I think, the three main groups of, or three main types of healthcare at home. And it dawned on me that a lot of people don't necessarily understand as well about the options of healthcare at home, sort of the moving parts of healthcare at home. It's hard enough sometimes when you're under stress in a hospital setting and a loved one's going to have surgery, or has been sick, or they're going to have to go to rehab after having knee replacement surgery or some sort of surgery. So the first question I'll ask is, I kind of come up with three primary types of home healthcare options. And if anybody wants to unmute, what would y'all see those three primary types of healthcare at home? Anybody want to take a gander at it? Somebody tell me something. Come on. What are the three types of care you might receive at home?
I mean, just nursing care, right?
Yeah, so that would be like home health care. Okay. Could also be, if you're needing to get moving again, it might be more than just nursing. It might be physical therapy, occupational therapy. Yeah. What about what we do? What my company, Atlanta Home Care Partners, does? We don't do skilled care, and I'll talk about that in a second. It's just more home care. Been able to help a number of Glen families, as a matter of fact, with home care, and I'll talk more about that. And the last, of course, is sort of more end of life. People say most of the time they refer to it as hospice care, but another piece of that is called palliative care, which is basically all comfort care as someone copes with a progressing illness or disease. So I'm saying that the big three are skilled home health, and I'm going to break these down and talk more about them in just a second. Home care, and then hospice. So the H's: home health, home care, hospice. And I'll start kind of in maybe the progression of them. And I used to work for Visiting Nurse Health System, which is the only nonprofit home health agency in North Georgia. And I'm going to refer to that all the time as skilled home health. And the key word here is skilled, because when I say skilled, that means you have to have a prescription written by a doctor. Could be a PA, physician's assistant, could be a nurse practitioner, but a clinician has to write an order for home health. And that means it's like writing a prescription for medicine. It literally is on the same kind of script pad. You might see them write you an order for some antibiotic. And skilled home health are services provided by trained clinicians. And those clinicians are primarily a nurse, hence like visiting nurse health system, physical therapy, occupational therapy, speech therapy. Those are the primary big categories. And sometimes they'll throw in a home health aide who will help with some of the more menial things like bathing, and things like that. So a home health order is usually prescribed after someone's had a hospital stay and they're getting ready to go home, or they've had a rehab stay at Bud Terrace or AG Rhodes. And I'm mentioning those primarily because those are the ones closest to Glenn. And they're getting ready to go home. Or even a visit to your doctor's office. Mom goes to see Taylor Graves at the Emory Geriatric Clinic, and he wrote her a prescription not long ago for physical therapy to help her kind of get stronger. Her balance is starting to become a little more shaky. So it has to be prescribed by a clinical person. That's why I say it is skilled home care or home health. People get home health and home care mixed up a lot. And the usual services are nursing, and that could be for managing a wound if you had had some surgery. It could be helping you manage your medication. Because think about this, somebody's in the hospital and they got a whole lot of medication that they're taking there. And then they've got a medicine cabinet maybe full of medication they've got at home. And one of the major causes of hospital readmissions is medication mismanagement, not getting things right, maybe taking too much of one and not enough of something else. And so skilled home health nursing is very often starts with medication management. They're going to get all your meds, they're going to put them out on the table, and they're going to make sure there's not any duplication of a green pill and a blue pill doing the same thing, that you're not supposed to take both colors, things like that. Wound care obviously is fairly clear cut. You've had a wound that is surgically healing, but it's not still severe enough to keep you in the hospital, but it still needs to be managed carefully so it's free of infection and stuff like that. So that's what a nurse is going to do in skilled home health. The other biggies are, of course, physical therapy. That's probably maybe even more prevalent than nursing, because you have people that might have been in the hospital for a number of days. They become, the term that you'll hear used sometimes is, they have become deconditioned. Deconditioned means they've been laying in the bed a long time. And so they are not as good with their balance, their mobility, their strength in their legs and things like that. So very often that's why physical therapy comes. And that physical therapy is for your gross motor skills, like walking, to put it bluntly. Occupational therapy is also really important, but it is more for some very specific skills in the home that involve physical manipulation. It could be making sure somebody knows how to tie their shoes or can do so safely. It can be working in and around the kitchen, but doing so safely. So occupational therapy is more fine-tuned than sort of the big picture of physical therapy. Speech therapy is more specific than the other two, and it primarily centers around, I would say, probably used more often after folks have had a stroke and their speech has been, impaired. They may or may not get it back. When my dad had a stroke in 2013, it was a little too severe and he couldn't quite gain any benefit from the speech therapy because they tried several times, but he had a little cognitive impact, and so he just couldn't kind of grasp it. And so they didn't follow through. But so occupational, so 3 therapies, physical, occupational, and speech therapy. And then you'll often have a home health aide. And that literally is somebody who's going to come maybe 2 or 3 times a week and help with bathing, what we call hygiene, bathing, grooming, showering, washing hair. And here's the thing about home health, skilled home health. Those folks get paid by the visit. And their job is to come and do the wound care, if it was a nurse, let's say, to do a session for exercises with the physical therapist. And then guess what? They're going to be there about an hour. And they're going to get in their car and they're going to drive to somebody else's house because they need to care for them. And that's also how they get paid. So you're going to find physical therapists or home health clinicians are there for a very specific purpose for a very specific time period. And they're not going to hang out for 8 hours a day while you go to your day job or something like that. And so that is frustrating to some people when they call and find that and they learn that home health doesn't stay for long periods of time. And that's where home care comes in, and that's what we'll get to next. How is home health paid for? It is covered by Medicare, Medicaid, and private insurance. How that is allocated over the number of visits and things like that can vary from provider to provider, but it is, because it is clinical. Again, it's written by a doctor. It's a huge difference. That allows it to be covered by your traditional health benefits. Couple of things to help with the navigation of that. If you're, let's say, Bruce, I'm going to pick on you in Melvin because I got a father-son here. If Melvin was in the hospital, you need to really have good communication with the social worker or the case manager who is following your dad, because you need to understand if skilled home health care is going to be beneficial to him. They have to order that before Melvin discharges out of the hospital, or if discharges out of AG Roads or whatever. Once a patient leaves a building, the clinicians there, they'll kind of put their hands up and say, not our patient anymore. It's especially true in nursing homes. So ask that question. Would my loved one benefit from skilled home health? Make sure that they write that prescription before you leave. And again, it can come out of the doctor's office as well, because Dr. Taylor Graves wrote a prescription for home health that's for physical therapy that my mom benefited from. So the kind of process is there'll be a visit to a facility, hospital, rehab, doctor's office. They will prescribe home health, skilled home health. Then they pass that information on to the home health agency of choice. It could be visiting nurse. There's several big ones in the Atlanta area. Kindred is another one. Amedisys is another one. Guardian is another one. The doctor's office will pass that on, or the hospital social worker or the rehab social worker. They're going to pass that information on to that home health agency. And that somebody would be calling you to set up a time to come do the admission visit. They come out and they ask you probably the questions that you have been asked 10 times before during your stay in the hospital or in rehab. One thing about healthcare, the moving parts of healthcare, they all want to hear the answer themselves. You can't say, well, I told them that at the hospital. That doesn't matter. They want to hear it from you. So you'll get asked questions that you've been through before. So they do an admission visit, and then they set up, then they say, okay, the nurse who's going to come visit or the physical therapist who's going to come visit will be calling you to set up the time. And that's how skilled home health works. And then they continue to see you until as you start to get better. The goal of home health is to discharge you, largely because you are getting better. There are times where they discharge you though, because maybe it's physical therapy and you've kind of plateaued off. You're not going to get any better. You kind of reached your limit. And guess what? Insurances and Medicare and Medicaid, they don't like paying for that. So they may not. You'll be visited. They'll determine what they call a frequency and duration. That means we're going to come see you 3 times a week for the next 3 weeks. Frequency, 3 times a week. Duration, 3 weeks. And then they will evaluate. And those things can, those moving parts can change over time. If somebody gets better from their knee replacement surgery and they're getting stronger and they can walk better and stuff like that, the physical therapist might say, beginning next week, I'm only going to come twice a week. And we'll do that for 2 weeks. And then we'll reevaluate. And then maybe down to 1 time a week. And then eventually they'll say, ta-da, you're healed. Or you're healed to the point where home health care won't benefit you anymore. So that's how that can happen. The last piece of skilled home health is that family education is really important. It's a major plank of home health care. If you have a nurse coming to take care of a wound, for instance, guess what? They're not coming every day. They might come 3 times a week. Well, they're going to teach you some basic wound care strategy or ability so that you can check and make sure something's not getting infected, or you have to change a bandage in general ways with fresh gauze or things like that. They'll show you that. Physical therapists will leave you. I think physical therapists are the kings and queens of Xerox paper, because they have exercises just, through the top that they will want you to do on the days they don't come. If they come Monday, Wednesday, Friday, they want you doing exercises on Tuesday and Thursday and Saturday. And guess what? They're good at what they do. They will know that you've been cheating on your homework if you haven't been doing those. So home health is extremely valuable, but it is for specific, health improvement purposes, like the wound healing or your ability to move around and ambulate more safely and with more strength. And so what do you do when you need somebody to kind of be there to assist you through the day, maybe for a length of time of hours, or maybe even overnight or 24/7? I don't think the Sanders family would mind me telling you that one of our dear members for many years was Ruth Sanders, and Ruth just passed away, in the last maybe 6 months, Susan, something like that. Anyway, Ruth had a stroke, and she was at Bud Terrace for a while, but then she was able to go home, and she needed home care to stay safe at home. And so Susan got us in touch with her niece, and we set it up, and then we provided home care to assist her with her activities of daily living. I'll say that again, probably several times. And we had caregivers from my company, Atlanta Home Care Partners, and they worked daily, or they were there 24/7, a team of several, for over a year. We're about a year, I think, is about how long Ruth lived, and helped her stay at home. And she was just down the street from Dan on Ridgewood. So when there are needs with the activities of daily living, and I'll throw some of those at you in a minute, you need to be looking at that other type of, healthcare at home called health care or home care. I'm not ever use the word skilled with it. The key word is assistance. And the care is always provided by what I think should be another abbreviation here, a certified nursing assistant. It's also called a CNA, or it could be a personal care assistant, a PCA. That's a state of Georgia certificate program, and they have to go to a class for several months and learn a lot of things about healthcare, vitals, and how to move people safely and not hurt their back and not throw the person on the floor and things of that sort. But that guarantees you've got somebody that's gone through training, and they are going to be available to assist someone with their daily needs for the number of days and hours each week that the family decides. And I'll talk more about that. Atlanta Home Care Partners, where I work, we're a state licensed agency. And I would always recommend that. There are a lot of what we call independent caregivers out there. Hey, my mom lives at Claremont Place, and there are a lot of independent caregivers at Claremont Place. When you are a state licensed agency, you've got some protection. That means the family has some protection. We have workers' comp insurance. So if a caregiver ever fell down and broke their wrist, they would be covered by the workers' comp. If they don't have that, they might be saying, hey, family, I fell in your home. I need you to help cover the cost of this. State licensed home care agencies also have liability insurance. They're also bonded. They also have a scheduler who can help should somebody have to call out because of a sick child or them being sick themselves. You know, you don't want to suddenly not have anybody there if it's a very needy situation for your loved one. And we also have a nurse. Most agencies do have nurses who help build what's called the plan of care. So how does that all work? Let's say home care is what's called non-clinical. So it does not require a doctor or a nurse or a nurse practitioner or a physician's assistant. It is a relationship that is developed between a family and the home care agency, because they recognize I can't be the caregiver for my mom or my dad at home. I can't continue to do that. I've either got my job I've got to get to, or in many instances, particularly when dementia or Alzheimer's or another, related dementia is in place, they're just getting worn out as being the family caregiver. And so they might contact Atlanta Home Care Partners or another agency and say, can we learn more about home care and talk about how you might be able to assist with the care of mom or dad? And here's a list. It got longer than I thought it did, but wanted it to. But the kinds of activities of daily living, what does that really mean? Things like medication reminders. Oh, baby, that's a big one. Again, you have to keep things straight. Hygiene, that's bathing, showering, hair washing, dental care, grooming, helping get dressed if it's needed, skin care, all forms of sort of ambulation, walking, moving around. It means the actual walking, but it also means transfers. That means if folks are fall risks, do they need help literally getting out of the bed, into a wheelchair or to the bathroom, to the shower chair, any kind of transfer, and then back, do those in reverse from the wheelchair or the walker to getting into bed if that's necessary. So fall prevention is really an important activity of daily living when folks are starting to struggle with their balance and things like that. Physical activity, we can help do those exercises the physical therapist from home care might have suggested or might say do on the days they don't come. So there's some overlap. Aging also brings sometimes incontinence. And so we can help manage that, changing diapers or Depends or other kinds of briefs, things of that sort. Light housekeeping. We always want to keep our homes where we work with clients safe and tidy. We did have one person ask us if we mowed the grass, but that was a little extreme. No, we're not going to mow the grass, and we're not going to sort through the files that have been in your basement for 40 years, that kind of thing. But our goal is to keep the areas of the home that are used clean and safe. And that usually means family room, bedroom, bathroom, kitchen, breakfast area, things of that sort. We do meal prep. It might take a while to learn your menu that you love, but home care, besides housekeeping, another sort of boilerplate type of care is meal preparation. Other things that help, taking out the trash, picking up the mail. One that can sometimes cause fear and trepidation with some of our caregivers is pet management, because we have several caregivers who have allergies, and cats are their nemesis. So we know that going in. So we wouldn't schedule a caregiver to work at that family's home. Transportation is also very often used. If family members are working, that makes it a burden to get mom or dad to a doctor's appointment or to go to the beauty salon, which I did with my mom last Friday. So transportation can really be a regular part of that. Social engagement. Some folks might live at home alone, and if and certainly it's been a huge impact this last 15, 16 months with the pandemic because of the isolation. And I've had several families tell me that mom or dad got worse during the pandemic because they couldn't visit them as much. If they had a hospital stay, they couldn't visit. If they were at a nursing home or rehab, they couldn't visit. And that really took its toll. So social engagement, companionship is often very important and very beneficial to the client and to the family. And notice this, you've been hearing me say the word client for home care. Remember, it's not a prescription. It's not like a doctor would write it. Some doctors and nurses, they have patients, but we assist with the activities of daily living. We're non-clinical, so we actually refer the folks we work with as clients. So there's kind of a difference there. We help some folks with computer assistance. We have to pick our caregivers carefully, but email, Zoom calls, surfing the web. We've had some clients who that was a way they communicated with their sons and daughters who lived remotely, lived out of state. And another important thing is I just refer to it as peace of mind for the family, because especially again, if they are not close by, they want to make sure that their loved one is safe. They want to make sure they're just, not laying on the floor sometime. I mean, I see my mom several times a week. My sister does too. So we're lucky, we're close. But we talk to folks all the time. A daughter who was a doctor in Connecticut, a son who lives in Chicago, things like that. They really want to make sure mom and dad are safe. So the goal is to build relationships. We want our caregivers to be like second family. And it takes a little bit of time to build those relationships, but they're really important. So how do you schedule it? How much? How many days? All like that. That's always a challenge. And there are financial implications to all that. Most of the agencies in the Atlanta area have a 4-hour minimum. And, again, this is what happens when Atlanta Home Care Partners and the family kind of sit down around the dining room table and talk about, well, this is what we would like mom and dad to receive help with. And then, then you start talking about, well, how often do you want them to be here? And how many days, how many hours? So it can go from 4 hours all the way up to 24/7. If somebody is an extreme fall risk and they have to get up during the night multiple times to go to the bathroom or something like that, it's not uncommon for us to have folks who literally stay overnight, do a 12-hour shift from 8 p.m. to 8 a.m. or something similar to that. And they
jump in there, and my understanding is when it's this type of care, just home care, that can be that the home care provider is the only person there, so they're the caregiver, or it can also be that they are there in addition to the other family members who live there, but to give them a break, what we call respite.
Oh, absolutely.
So that I can sleep through the night knowing that my loved one is going to be cared for by their home care provider. And so I know, and the same thing with the, when you mentioned the transportation. So there's a difference there are some senior care transportation services. I'm not sure if they've lasted through the pandemic, but kind of, we joke there's some Uber for older adults or just Uber, but that's door to door. Whereas this is the home care provider is a companion to go with someone. They don't just provide the transportation, they're going through the door and going, sitting in the waiting room or sitting with
Yeah,
them.
they're going into the doctor's office. Yeah,
It's like
exactly.
having a companion with you,
Yes.
which is a lot different than just transportation. And so for those two, the transportation and the kind of overnight care, I wanted to clarify that there are companies that provide those limited services. And so a lot of people, especially working with their family needs or their budgets, will kind of hodgepodge this service and that service, but it really does help when people have the opportunity and the means to consolidate into one caregiving agency.
Yeah, I mean, and I won't mention names, but Susan, we know we have a family we're working with now, and the mom is a teacher, and she's going to be going back to school at the end of July, and she says, I've got to get my rest. I've got to be able to sleep at night, or I would just be toast, trying to teach during a busy day like that. So we're literally working with that family, overnight, several days a week, 2 days a week for starters, so she can get her rest. And she and her son split the duty right now, but that'll change when he goes back to school and she goes back to school. And she says, if I don't get rest at night, I won't be good at my job as a teacher. So you're absolutely right. Well, here's a phrase we use a lot in home care for the caregiver. And the last thing you can afford to do, if you're the primary caregiver for someone who has a disease or an illness or something like that, you can't wear yourself out because you're really important to that person. And so if home care can come in and provide some assistance and take the burden off of you so that you can be a son or a daughter or a spouse again and not have to think about, oh gosh, what have I got to do next? Well, I've got to remember to do this. We often use those kind of two thoughts about care for the caregiver and letting our caregivers take on the burden. And so we've over the years we've actually even had a few caregivers make out of town trips with clients to be with them while they're on the road, at the cottage, at the cabin in the mountains or the beach house or something like that. So with home care, there's a lot of family agency interaction to sort of determine what would be the best, what we call plan of care. And a lot of times it's me getting it started. I'm not a clinician, but I am an old science teacher, and I've been doing home care and home health and hospice for like 25 years. So, you're really just finding out from the family, what does your mom or dad or your sister or whatever, what do they need? What are the best ways we can assist them so that they can function at their best as their health status allows them? And so that's why those meetings with family are so important, because guess what? They know what the best types of assistance are. In many instances, they're actually almost showing our caregivers how to do it so that we can replicate it as closely to the way they do it, so that the person needing the assistance, maybe walking to the bathroom if they have had some sort of debilitating injury to their body, so that walking is hard. Let's do it the same way the family member does it, so that the client with the need feels comfortable. We're not trying to do it differently from them. So it's important. Now, so we're going to determine, we would go and decide how long we're going to be with somebody, how many days. That means you have to think about, okay, how are we going to pay for all this? And this is the downside of home care, because it is non-clinical, because a doctor doesn't write a prescription for it. There are two ways it's paid for. There's private pay, that's money out of pocket, or if a family is lucky enough to have long-term care insurance, that will help defray the cost. But more people do not have long-term care insurance than do, is what I've seen. I'll be quite candid here. My mom has long-term care insurance, but Mackay Asbury does not have long-term care insurance. So I better stay healthy, when we get to that. That is something, again, that comes into consideration with how much, you can afford. because it's the going rate, and I'll be again quite honest, for home care in the Metro Atlanta market is anywhere from like $23 to $25 per hour, and that can really add up. And we have some family situations where it's care not just for one person, it's mom and dad. It's care for a couple, and that's around $30 an hour. Imagine, of course, it should be a little bit more. So anyway, that's how those considerations, is this balancing act between helping with the care for those activities of daily living that will benefit somebody, but balancing that with the financial, implications of all that. So it's a struggle sometimes. I mean, a few lucky people have fairly deep pockets and they can afford whatever they need. Maybe they have the long-term care, maybe but then others have to kind of try and balance it with relief and respite, as Susan said earlier, for family caregivers, but still providing some assistance when needed. So when you're doing skilled home health that I mentioned earlier, you're talking to a social worker or a physician or another clinician about those services. How do you kind of instigate or get home care off the ground? Well, one thing at Glen Church, you can talk to the lady wearing the yellow blouse, Susan Pinson. She's a great resource. She knows me. We know each other so well, but she's also she's in charge of congregational care, so she's got a lot of resources at her disposal that she could always pass on to you. But if you needed home care, she would say call Mackay at Atlanta Home Care Partners. And then we would kind of get the ball rolling. We, either start on the phone, make a visit, and talk about how we can best help, not just the client, but also helping the client usually means you're helping the family. So we would talk about that and see where it leads us. And when you make that first phone call, that usually leads hopefully to a home visit. We call it an assessment visit. Doesn't cost anything. It's the cost of doing business. But it's a time to learn from the family what are the best ways we can assist the specific task or those activities of daily living. They got the meals planned. The spouse might say, I got meals covered, but he's a fall risk and he's too big for me to pick him up if he falls on the floor. We need help with that regard, with his bathing, with hygiene. Again, of those things that we talked about, all the mobility issues, all the incontinence or hygiene issues. Certainly the housekeeping is important. Whenever I talk to my mom and whenever I talk to folks who are, asking about possible assistance, when we get to the housekeeping and the laundry linens, I want to know, how does anybody like my mother, who's 93, how does she get the far corner of that fitted sheet on her bed? It's hard for me. And so we can certainly help. And again, guess what that does? It takes some of the burden of upkeep of the house and fresh laundry, linens, things like that. It's something we take on so that they don't get worn out trying to do some of those things. The goal, there's overtime rules out there in the world of work. And if we're going to be with somebody for 7 days a week, let's just say 8 hours, 7 days a week. Well, let me see, 7 times 8 is 56, if I'm not mistaken. Well, you can't have somebody there 56 hours. One, they need a day off, but when you hit 40 hours, labor law says you pay them time and a half. So that usually means you'll find out again, if the hours are extensive enough, you're going to have a team of caregivers. So you're going to have 2 or 3. And in the instance of somebody going 24/7, it could be 5 or 6, because again, you've got to break that up into kind of 40-hour or less components. If you work 3 shifts of 12 hours, you're already at 36 hours. So if you engage an agency like ours to provide some care and you're going to have a lot of hours, you have to understand that you're going to have several caregivers. The goal is to create a consistent team. So you might have Tiffany and Barbara and Sarah on your team, but we want it to, as much as possible, be Tiffany, Barbara, and Sarah every week, each week. So that's the goal. And I'll be very honest, and Susan mentioned this earlier, the pandemic has been a real challenge. A lot of caregivers stepped back because guess what? As I say many times, public education is a wonderful form of childcare because it keeps the kids at school. If they're playing a sport or doing after school activities, suddenly that you've got a caregiver who can work from like 8 o'clock in the morning to 5, 6 o'clock in the evening. And we had some that had to step back from working as much because suddenly their 3rd and 4th grade children, they're not in school anymore. They're at home. And so through the lockdown portion of the pandemic, it was challenging for almost every healthcare entity, be it home care, home health, certainly the nursing facilities, and even hospitals. You would probably see a hiring now sign out in front of almost every one of those. And so it's getting a little better now. People are getting back into the workforce. There are also some government programs in place that have given them some, I'll call it free money, which means they maybe been less inclined to come back to work. So that's important. Atlanta Home Care Partners, another thing I like about it is we're locally owned. Cheryl and Lewis Mann, Lou and I played Little League together at Medlock Park. He's a year older than I think Mr. Wiley right there. Lou is class of 72 from Druid Hills. So we went to Fernbank and Druid Hills. So I just like the fact that they're local, they're very engaged. And sometimes there are questions that come up about caregivers, about ways we could do things better or differently, or we need to change our schedule and things like that. And if you need to talk to the owners, it's good to have somebody, I think, that is very approachable and actively involved with the business, that kind of thing.
Well, speaking of questions, we do want to give time for questions, Mackay.
Yeah.
Given us a lot of great information. One thing I did want to throw out that different companies provide too, if all of this seems really overwhelming to you, and if you have any friends or family and these approaching these times when you're going to need to be making these decisions about home care options, or beyond that, moving into a retirement community or all the different levels of personal care home and assisted living, if all of that makes your heart start racing and it's just too much, there is a beautiful thing now that usually it's social workers and other occupational therapists and such go into, called just senior care managers. And so there's several companies that Mackay and I both know and refer to some that you basically get your own senior care manager to talk with you and your family about your needs and kind of helps you put all the puzzle pieces together, and they help manage that.
And so one of them is our church member.
Yes, yeah, we've got a church member who does that with the company she works with, and then on the other side, of course, there's the financial and legal side where elder care attorneys that specialize in all the paperwork of getting all your all your paperwork and financial stuff in order with all of that. So we don't want anyone to feel overwhelmed. It is overwhelming, but there are so many amazing experts in the Atlanta area that we at Glen are very blessed to be interconnected and supporting our community. So I just want to throw that out there, but then also questions for Mackay while we still have you a couple more minutes. Carolyn,
Mackay.
Unmute, I think, Carolyn.
Either Melvin or Carolyn.
Melvin, go first.
Okay, sure. Yeah, I want to share this news with the group that I heard this morning, national news. And this was the year 2020, last year, that the death rate in nursing homes were up 32%. So that tells us something.
It does.
But I want to tell Mackay, I think you must have went to a makeup studio before you came on. You look better on the screen than you do in person.
And Melvin, you saying something like that, I got to tell you that my mother asked me last week, hang on, did we lose it? hang on. There we go. My mother said, I wish she was at church, and she said, I wish Melvin was back at church. That's what my mom said. So she would love to see Bruce get brave one day and bring him, okay?
Yeah.
I tell you, your dad would be proud of you to hear in this presentation.
Thank you. I had a good mentor in him. So, Carolyn, you had a question.
Yes, and it has nothing to do with fashion statements that Melvin makes,
He does.
but we appreciate having a role model like Melvin to be a fashion statement. What I'm asking goes way back to speech language pathologists who do all the things related to regaining speech, but they also work with swallowing, which follows a stroke so frequently. Does anyone ever go home from a nursing home with swallowing disabilities, swallowing difficulties that they need more help at home with, like
a feeding
texture.
tube, like a feeding tube.
Oh, I did not like that's not my favorite word, but with just learning to eat or to swallow again.
No.
And fluid consistencies, that's the word I'm looking for. Okay, thank you.
That's a great question. No, that's what a speech therapist also is involved with. It's not just for gaining speech, but the swallowing is huge in that regard. And I know a number of people meet kind of limitations in their swallowing, and that's when I mentioned the feeding tube. I know we've had several clients who have had sometimes it's called a feeding tube. Another name for it is like a peg tube or a JPEG or something like that. And they've literally put a little opening with a special, seal on it that's got a special apparatus that would allow you to put nutrition from like a feeding, like a bag for fluid that would either be pushed or let gravity feed into that so that you can get the nutrition you need. They also use those kind of tubes for medication as well, because again, if you can't swallow. So I'm sure that, at a rehab facility or even in a hospital setting, efforts would be made to, I think, remedy swallowing and, difficulties like that. But I think they do that assessment, and then some of their recommendation for how they can address continued progress, maybe in those ways at home. If they say we don't think they're going to be able to swallow, foods and nutrition or liquids and things like that, they might then say we're going to put a feeding tube in before they discharge from the hospital or something like that. So no, but you're right. It can be very limiting. And when you said fluid, containment or something, I always learned fluid. I called it fluid management.
Oh, okay.
Yep, because my dad had that. He had to be suctioned because he couldn't swallow a lot of the the liquids that our sinuses and throats and mouths kind of produce, and it was a real limiting factor for him. So I didn't know our bodies produce so much fluid. That's what I learned when my dad had his stroke. So it's a good question, though. Yeah.
Thank you, Mackay. I appreciate your defining and explaining some of that.
And one thing I'll say too is, Susan, I'll make sure I'll just email you this at some point, but if you ever want to link to our website, which again goes into a lot of what I've just spoken, and I know I threw so much at you, you might have taken in some of it, but I can always provide you with a link to our website, and it's again would reiterate and summarize a lot of what we've talked about today, more for home care. And of course, we work with home health agencies side by side, because sometimes we're doing the home care for the longer hours, yet they're coming 3 times a week to do the physical therapy. Or we didn't really talk too much about hospice care, but if hospice is coming in, we work side by side with hospice as well. Again, we're kind of the kind of care for the long haul, meaning multiple hours, multiple days. And those are more home health, and hospice are kind of more, they got more specific to their meat on the bones. And we do, like it says, those activities of daily living. Well, those don't stop at the end of the day. There is no end of the day in some regards. So, yeah. Thanks. Thank y'all for jumping on. I appreciate it. It's good to see everybody. I know I've seen several of you at church, and I enjoy that a whole lot too. So I hope the participation at 11 o'clock will continue to grow again. Yeah. Thanks, Susan, so much.
Thanks, Mackie.
I think we're through. Are you off?